Hello everyone, this is Dr. Madhusudan Rao and the program I teach medical students. Today my lesson is on the topic ventricular septal defect. Ventricular septal defect is the most common acyanotic congenital heart disease that we are going to touch today. Well, this is an infant that being examined for congenital heart disease. This is another infant in the pediatric ward admitted for the evaluation of the congenital heart disease. This is another infant that is being examined and evaluated for the congenital heart disease. Well, what is common in all these three infants? They are being examined by the doctor. What is he doing? He is auscultating the heart. Well, remember, my dear students, you go by auscultation while examining the infant for congenital heart diseases. And routine steps of examination of the cardiovascular system in terms of percussion, palpation, etc., you need not observe while examining the infant for congenital heart diseases. Auscultation of the heart should be taken as the first step in order to pick up the sounds and murmurs in the infant. It is for this purpose I brought these photographs for your understanding. Well, this is the picture showing the hole in the ventricular septum, viewed from the right side of the section of the heart. And this is the ventricular septal defect. This picture demonstrates direction of blood flow from the left ventricle to the right ventricle. Oxygenated blood that is received from the pulmonary veins into the left atrium, which is in turn pumped into the left ventricle, is shunted into the right ventricle through the intraventricular septal defect. So, which in turn flows into the pulmonary circulation, gets oxygenated, and further received by the left atrium through the pulmonary veins. This is the brief account of the direction of flow of the blood from the left ventricle through the defect into the right ventricle and further received by the left atrium and being pumped into the left ventricle. And this is the septal defect, ventricular septal defect. The defect is marked by the red dots. It is the margins of the ventricular septal defect. But this defect is not in plane with the rest of the septum. That's why current definition of the ventricular septal defect is the interventricular communication. Because ventricular septal defect, as it was defined earlier, as the hole marked by the borders with deficiency of the ventricular septation. But currently, this definition is being replaced by the term interventricular communication, because all the ventricular septal defects they are not in plane with the rest of the ventricular septum. This is the new terminology for the ventricular septal defect, that is interventricular communication. The only reason is that VSDs are not in plane with the rest of the septum. But all the interventricular communications are not true ventricular septal defects. This is again a controversy. But you can use any term you want. Well, few points about the introduction of VSD. It's the most common cardiac malformation, either in isolation or in combination with the other defects like double outlet right ventricle or tetralgia Fallot. It is a component of this complex anomalies. It accounts for about 25% of the total congenital heart diseases. Then VSD is divided into two varieties. Number one is it could be membranous or muscular. Membranous, again, it could be posterior, inferior, or infracrystal or supracrystal. But whatever the anatomical location of the VSD, the clinical findings are the same. They do not vary. It is for the purpose of the cardiothoracic surgeon who does the repair of this particular defect. It is important to know the location of the ventricular septum defect with regard to the membranous or muscular. But clinical importance is not going to vary much. Posterior inferior is the most common one, which is close to the septal leaflet of the tricuspid valve. Infracrystal is important because it is associated with the Fallot's physiology because of the presence of pulmonary stenosis. That is because of the associated infundibulary hypertrophy. It may set in tetralogy of Fallot's because there is obstruction to the outflow tract of the right ventricle and there is ventricular septal defect because of the high resistance for the outflow of the right ventricular output. You may get the reversal of the shunt at the ventricular septal defect, resulting in Fallot's physiology. This is common with the infracrystal location of the ventricular septal defect. Supracrystal is usually complicated by aortic regurgitation. Then coming to the muscular types, it could be mid-septal or apical or single or multiple. By and large, it is the membranous type of the ventricular septal defect which is more common. Yes, this is the diagrammatic representation of the ventricular septal defect. When the left ventricle communicating with the right. Well, this picture shows presence of the ventricular septal defect, a muscular type located close to the apex. Having known the types of ventricular septal defects, let's go into the pathophysiology. Pathophysiology depends upon the size of the shunt, size of the defect, and degree of pulmonary vascular resistance. So these are the two important determinants of the magnitude of the shunt. Number one is the size of the defect, and number two is the pulmonary vascular resistance. Size of the defect. It could be small, it could be moderate, it could be large. A defect less than 0.5 square centimeters is described as a restrictive VSD with limited left ventricular to right ventricular shunt. There is limited blood flow from the left ventricle to the right ventricle because it is restrictive ventricular septal defect. And right ventricular pressure is normal. In moderate VSD, which is relatively restrictive, it is size is 0.5 to 1 square centimeters. There is moderate left to right shunt. There is increasing right ventricular pressure. What is moderate VSD? It is relatively restrictive VSD with the size of more than 0.5 square centimeters. It lies between 0.5 to 1 square centimeters in diameter, with moderate left ventricle to right ventricular flow, with progressively increasing right ventricular pressure. Whereas a large VSD, which is non-restrictive VSD, more than 1 square centimeter in diameter, RV, LV pressures are equal more or less, and the magnitude of the shunt is dependent upon the ratio of the pulmonary to systemic vascular resistance. Well, these are the features of the VSD depending upon the size. Coming to the vascular resistance. At birth, pulmonary vascular resistance is very high. That results in the limited shunt across the defect. And so, the infant at birth is usually asymptomatic. So, after a few weeks of life, there is increasing magnitude of shunt. That is because of the falling of vascular resistance due to the remodeling of the pulmonary vasculature. During infancy, there is increasing shunt, increasing blood flow to the pulmonary circulation because of the fall in vascular resistance. That results in the hyperdynamic pulmonary hypertension. Well, in childhood and later part of the life, what happens? There is setting of pulmonary vascular disease because of the damage to the pulmonary vasculature, which is subjected to the continuous pressure trauma, and that ultimately results in the pulmonary vascular disease and the reversal of the shunt. This is the evaluation of the pathophysiology depending upon the size of the defect and the presence of pulmonary vascular resistance. This is one more factor that is associated with the pathophysiology. That is QP and QS ratios. That is ratio of the pulmonary flow to systemic flow. If the flow ratio is less than 1.7 to 1, it is small shunt. The cardiac samples of normal size, pulmonary vasculature is normal, and child is asymptomatic. If the QP-QS ratio is more than 1.75 to 1, it is associated with moderate shunt. And a ratio of more than 2:1 indicates large shunt. Volume overload of the left atrium and left ventricle, and increasing pulmonary arterial hypertension. And there is enlargement of the pulmonary artery, left atrium, and left ventricle. Then, what are the categories of VSD? These are muscular, perimembranous, ventriculoatrial, that is from the left atrium to the left ventricle to the right atrium, that is ventriculoatrial defect, supracrystal or infracrystal, or inlet defects or outlet defects. Coming to the inlet defects means that is the first one, that is inferior lateral defect, that is close to the septal leaflet of the tricuspid valve is inflow defect. In the same way, infracrystal is also inflow defect. right? But these are the anatomical aspects of the interventricular septum. The thing is like that. The outflow deflects are usually associated with the pulmonary hypertension. That is right ventricular obstruction. That is, there is a right ventricular outflow obstruction in the outflow defects. That is usually the infracrystal defect. Whereas inflow defects lie in close proximity to the septal leaflet of the tricuspid wall. So this is the point. If you are interested, you can remember. Otherwise, leave it. Just remember, the ventricular septal defects are two types. One is the membranous, other is the muscular. Okay, membranous is more common. If it is close to the septal leaflet of the tricuspid wall, that is most common one. If it is in the outflow tract of the right ventricle, it leads to the pulmonary obstruction and results in fallous physiology in the course of time. And if it is in the supracrystal location, it complicates aortic regurgitation. So you remember these important points, that's all. Beyond that, not required. Coming to the clinical manifestations, there are certain factors influencing clinical manifestations of ventricular septal defect. Number one, whether it is isolated defect or is associated with the complex anomalies like phallus tetralogy, etc., or double outlet right ventricle. And size of the defect and pulmonary vascular resistance are the two important factors that influence the clinical manifestations. And the lung compliance and the work of breathing and pulmonary to systemic flow ratios are other factors that influence the clinical manifestations in VSD. Coming to the clinical manifestations. Unusual to produce symptoms at birth due to pulmonary vascular resistance is very high. Because of the high pulmonary vascular resistance at the time of birth, the magnitude of the shunt from left to right is very minimal and there are no symptoms during this period of life. Becomes symptomatic by 4 to 8 weeks. This is because there is remodeling of the pulmonary vasculature, gradual fall in the pulmonary vascular resistance, and there is increased shunt, and symptoms occur resulting in the volume overload of the lungs. Symptoms, they have earlier onset in premature infants when compared to the term infants. They are could be growth failure, features of congestive heart failure, pulmonary edema, and recurrent wheezing and respiratory infections. When the child is growing from infancy down to the childhood, there is gradual fall in the pulmonary vascular resistance and increasing blood flow into the pulmonary circulation, and there is growth failure, congestive heart failure, and recurrent respiratory infections and wheezes. Growth failure. This is because of the increased caloric expenditure or decreased supply of nutrients to the tissues. Why there is increased caloric expenditure? This is because of the increased pulmonary blood flow, increased pulmonary arterial pressure, because arterial pressure gets increased because blood is pumped into the pulmonary circulation at high pressure directly from the left ventricle through the ventricular septal defect into the pulmonary circulation. That results in the pulmonary edema, reduced lung compliance. When there is the lungs are flooded with fluid, in the interstitium. They become stiff and they become poorly compliant. That results in the increased endobronchial secretions, recurrent wheezes, and increased hypersensitivity of the airways. All these factors results in increased workup breathing. That's how the growth failure sets in because of the increased caloric expenditure. Decreased supply of nutrients to the tissues. The child is eating, but there is associated with the poor feeding. But supply of nutrients to the tissues is deficient. That is because of the reduced cardiac output. The most of the left ventricular ejection fraction, it is being shunted across the interventricular septal defect, and there is reduced blood flow to the tissues. That results in the decreased supply of nutrients to the tissues, thereby resulting in growth failure. Then coming to the clinical manifestations. Just with regard to the small VSD, how does the small VSD present to you? It is the most common, small VSD is the most common one. Usually asymptomatic. This particular lesion is diagnosed and identified accidentally when the child is presented to you in the outpatient department for regular checkup. When you auscultate the heart, you will find a harsh, loud, pansystolic murmur at the left lower sternal edge, associated with thrill. That means murmur is more than grade 3. And classically, the murmur stops short of second heart sound. You please remember this point. Coming to the large ventricular septal defect. Child will be having recurrent chest infections and presented to you with the signs of congestive heart failure. When you examine, there is left precordial bulging, palpable parasternal heave. This is all because of the right ventricular hypertrophy. Apical impulse is displayed laterally, that is, apex is shifted more out and down, indicating the left ventricular dilatation. That is because of the volume overload of the left ventricle. You can feel systolic thrill, and apical impulse is forcible. Forcible apical impulse indicates volume overload of the chamber, whereas heaving apical impulse is due to left ventricular hypertrophy. That is seen in the conditions of pressure overload, that is aortic stenosis. Then you'll appreciate a pansystolic murmur, which is less harsh than the one you auscultated in the small VSD. It is less harsh and blowing in character. And P2 is loud because of the increasing pulmonary arterial hypertension. P2 becomes loud. And you may appreciate mid-diastolic murmur, a low pitch rumble due to increased flow across the mitral valve from left atrium to the left ventricle. The presence of mid-diastolic murmur is indicative of pulmonary to systemic flow ratio is more than 2:1. This is the significance of presence of mid-diastolic movement at the mitral area in VSD. Well, with these findings of symptomatology and the clinical signs, the positional diagnosis of VSD could be made easily, but it can be confirmed by X-ray chest, ECG, and 2D echo. What are the findings with regard to X-ray chest? X-ray shows in these patients with dilated left ventricle, dilated right ventricle, enlarged left atrium, and dilated pulmonary trunk, and associated pulmonary congestion. These are the findings you see in the X-ray with a patient with large VSD. So you see the dilated right ventricle, dilated pulmonary trunk, left atrium, and the left ventricle, and showing the pulmonary congestion. Next, ECG shows biventricular hypertrophy. And echocardiography, you can see the ventricular septal defect with the shunting of the blood from left ventricle to the right ventricle. Then what is the prognosis and complications? A word about it. Ventricular septal defect closes spontaneously in 30 to 50% of the small defects in a period of 1 to 2 years of life. Right? And 80% of the small muscular defects close. Majority close before 4 years of age. If they do not close by 4 years of age, it is not going to close at all. Small defects remain asymptomatic, and sometimes some of the large defects, they become smaller in course of time. And another complication of the VSD is development of congestive heart failure. The child may present to the emergency service with signs of congestive heart failure, which has to be treated effectively to reduce morbidity and mortality. And pulmonary arterial disease is another complication, that is asymmetrical physiology, with the development of the pulmonary vascular disease and reversal of the shunt. At which time the condition becomes inoperable. And other complication is the subacute bacterial endocarditis. And aortic regurgitation, arrhythmias, subaortic or pulmonary infundibulous stenosis, sometimes leading to death, are some of the consequences of untreated large VSD. Then how do you go about treatment? In asymptomatic small VSDs, give assurance to the parents, but advise prophylaxis for infective endocarditis and advocate periodic follow-up, which is very important, during which if the infant is having features of congestive heart failure, treat congestive heart failure. Well, you advocate surgery. Number one, if there is failure of your treatment to control the symptoms of congestive heart failure, and infants of 6 months to 12 months of age with large defects and pulmonary arterial hypertension should be treated. This pulmonary hypertension is not due to the pulmonary vascular disease, it is hyperdynamic pulmonary hypertension. So the infants of 6 months to 12 months of age with large ventricular septal defect should be operated. Children over than 2 years, older than 2 years, with QSQP ratios more than 2:1 should be corrected surgically. And ventricular septal defects, supracrystal type of any size, because they have the risk of aortic regurgitation, should be corrected surgically. Understood? And severe PVD, pulmonary vascular disease, is a contraindication for surgery. Remember, severe PVD is contraindication to surgery. These are the important steps of management of the child with ventricular septal defect. Thank you very much for patient listening. If you like my video, subscribe to my channel, and we'll meet you again in the next class. Until that time, bye bye. Thank you.